Your clinic is in studio, and we will take your questions. If you would like to text them to us, I'd really appreciate that method. It's better, it works better, I think. 507-838-5233 is the number. In fact, I better get out my phone here just in case you do text us. 507-838-5233. Thanks for coming in, Dr. Muench.
Thanks for having me, Gordy. Appreciate it. Always good to be here.
Oh, yeah, fantastic. So how's it been going? Have you been busy?
It's been very busy, yeah. Interestingly, you know, the end of the year rush is always frantic, and everybody wants to get their surgery done before the end of the year because their deductible is all paid for, and that rush has kind of spilled over into the first of the year here. It's been steady, been real busy.
Plus, I'm sure they'd like to get it done before spring sprouts so they can get out in their gardens and do all that sort of thing.
Yeah, it's very true. Summer in Minnesota is short enough. People don't want to miss it recovering from surgery.
And you can still work in your garden if you've had a knee or a hip replacement.
Yeah, you sure can. I mean, we encourage people to continue to be active after joint replacement. That's the whole reason we do the surgery.
So what do you do the most of?
We do a lot of hip and knee replacement. We do a lot of shoulder replacement. We do a lot of all three.
Okay, there's no one that really stands out?
Probably, I think nationwide, I think more of us, everyone does more knee replacement than the other two. It's usually about 2 to 1 knee replacement to hip replacement.
Because think about how much pressure is on your knees.
Yeah, you're right, an incredible amount, and obviously it's a big problem, and so we do a lot of it.
And when Dr. Stromer was on the program here a few weeks back, he had mentioned, you know, losing weight is huge in terms of preventive measures, so you never have to do a knee replacement.
It is. I think that's a very important part of the treatment plan for symptomatic arthritis is weight loss, because it's not linear 1-to-1. You know, for every pound you lose on the scale, you're probably losing 5 to 7 pounds on your hip and knee especially when you do activities like climb or descend stairs. So, you know, for every pound you lose, you're losing a lot of force on your arthritic joint.
I mean, I knew it was some, but I didn't realize it was that much.
Yeah, it's a lot.
It really is. So I've lost 20 pounds since the first of the year.
Yeah, that's impressive. That's a lot of weight off your joints.
I never thought of it that way.
Yeah, there you go.
And I was a catcher in high school. I've got bad knees. We didn't have knee savers back in my day.
Sure, yeah.
Be honest with you, Doc, I wished I would have invented them.
Yeah, it's a good idea. It seems like it takes some pressure off your knees.
And it's such a simple idea, too. I remember the first time I saw it, I banged myself in the head, so why didn't I think of that?
Exactly.
You know what I'm saying?
Yeah.
I wouldn't be sitting here today. I'd be a multi-gazillionaire.
Yeah, that's probably true.
Although I do know some youngsters, some high school athletes around the area who don't wear them. They said they don't like them, which blows my mind. I said I'd wear them. It saves your knees.
Yeah, seems like it would be a good idea, but who knows? I don't know if there's any science to back it up, but it sure looks like it would be more comfortable.
Right. How many years have you been an orthopedic surgeon?
Coming up on 15. I started here in town August 1st, 2001.
You remember your very first operation?
I do, as a matter of fact, yeah. I do remember, interestingly.
Was it a knee?
No, it was a hip fracture.
Were you nervous?
I wasn't, actually, because we have such a good training program that I knew how to do my job well, so I was confident.
Okay. So this was not your first rodeo. You were at other places?
No, but it's fresh out of the training program at the University of Minnesota. But it's a rigorous training program, and they train you well, and so you know how to do your job well. So.
Okay, so you were very confident.
I was.
How much has it changed since you started 15 years ago?
It's changed a lot. You know, the materials that we implant are always getting better. Techniques are improving, more efficient techniques, ways to do things, and the way we control pain afterwards has changed a lot, and that's really made hip and knee replacement a lot less painful.
Because it is painful.
It is. It's horribly painful.
Well, think about it. You're taking the whole knee out of your.
Yeah.
It's the biggest joint in the body, right?
Yeah, and you know, I remember when I first started, we would do knee replacement, and people would be miserable for the first 2 nights. They were in miserable pain, and we do so many different things now to make that pain a lot better. It's not pain-free, don't get me wrong,
no.
but people are far more comfortable than they were.
Well, I've talked to a lot of people who have had them done, and to a person, they say, I should have done this earlier.
Yeah, that's a real common statement after joint replacement. You know, once we get you recovered, your joint functions way better than the one you were dealing with before.
But I know you guys, as a group, tend to frown on doing them too early, right?
Yeah, we try not to. You know, sometimes you're forced to because the arthritis is so bad and the pain is so bad that people can't function. They just don't want to live that way. But the thought is that the younger you are when you have a joint replacement, the more likely it's going to wear out in your lifetime and have to be redone. And the results of a revision are not as good as the results of the first time.
Okay. All right. We're going to visit more with Dr. Muench, and I will take those questions. Hopefully some of you very educated listeners will text us some questions. Maybe you've been through the procedure and you know a little more of what to ask than I. I have not been. Got some wood around here. Hopefully I don't have to undergo those procedures, to be honest. I think most of us do. We'll do that when AM Minnesota continues, but right now we're going to get that opening market report, a service of Ag Power Enterprise.
Watching the direct cash cattle markets and waiting for widespread trade.
And I
Pretty
sprained
typical
my
Wednesday
meniscus.
so far with no real pattern or inquiry as of yet. April lives up 12 at 133.65 and June 17 higher at 123.02. April feeders are down 32 at 154.95. And hogs are mostly lower, with most contracts moving in the cash index. There's also some position squaring ahead of April's expiration at noon Central tomorrow. April is steady at 66.60. June's down 42 at 78.77. The Dow's up, crude oil's down. John Perkins.
Thanks, John. Certainly appreciate that. Again, your opening market report is a service of Ag Power Enterprises, your John Deere dealer. They have locations in Owatonna, Hollandale, Belle Plaine, Osage, and Northwood, Iowa. Northland Buildings for quality post-frame construction. Go to the website northlandbuildings.com. Northlandbuildings.com. That number to text your questions, again, is 507-838-5233. 507-838-5233. And even if you don't have a question, if you have a comment, let's say you had a procedure completed, you can also text us and let us know about that. Dr. Clint Muench is with us from the Orthopedic and Fracture Clinic. You not only serve here in Faribault, right, Doc?
I go to Northfield also, yeah.
That's what I thought.
Yeah, and my partners go to Farmington, Lakeville, so we're kind of all over the place.
Right, and I know there's a facility in Mankato, but that's not the same group?
It is the same group, yeah. That's where we're based out of. That's where I have 7 or 8 partners over there, and then we have a couple in Hutchinson also. And we service all the small towns around Mankato. So.
Sure. Where'd you grow up?
Prior Lake.
Not too far.
I didn't get too far.
So you get home much?
Not too often. My parents are still there, but mostly they come down to our house and see my boys down here.
Well, there you go. You can't beat that.
Yeah.
And you're living right here in Faribault?
Northfield.
Okay.
Yeah.
Northfield.
Yeah.
Fantastic. Again, when you set up an appointment at the Orthopedic and Fracture Clinic, I can just call you and say, do I need to tell you? Well, tell us what we need to do.
It depends on your insurance company, but most of the time you don't need a referral. Like let's say you're injured playing volleyball on a Tuesday night or something, then you twist your ankle or something happens, do the normal stuff that your mom told you, the rice method, rest, ice, compression, elevation. I would say do that overnight and see how things feel. And if the next day it's horrible, things are not good, then give us a call, and we've always got somebody available that can see you Monday through Friday, so we can get you in and get you an evaluation and see what you need as far as the plan to get better.
Yeah. In fact, wouldn't you recommend that as opposed to, I'm not trying to take business away from physicians, but it seems to make sense to me because a physician really can't do a whole lot other than refer to you.
Yeah, oftentimes that's the case, medical care is expensive, and patients are being asked to pay more and more out of their own pocket, and so if you've got a serious problem that requires our attention, we're happy to see you right out of the chute.
Does insurance cover knee replacements, hip replacements, shoulder replacements?
They do, yeah, and it's like anything else. Your out-of-pocket expense depends on your insurance coverage, insurance carrier.
But what we talked about earlier, the age, is that a factor in whether or not insurance covers it?
No, it's not so much. People 65 or older are usually Medicare, obviously, and then people younger than that are more the private insurance companies. But no, they across the board cover joint replacement surgery.
We're more and more active, aren't we, these days?
Yeah.
And elderly people are, my dad played tennis in his 70s.
Yeah, people are living a long time, especially around here. The number of patients in their 80s is incredible. And like you said, they're all very active. They don't want to slow down, which I think is great.
It's, they do garden work. I know a lot of people, and you're getting up and down a lot when you do that.
Yeah, a lot of traveling. People around here love to travel, especially in the winter months. And then, like you said, sports activities even into their 70s and 80s.
That's awesome.
It is. It's
and
great.
I know you would recommend staying that way too, right? Activity
I
is
would.
good.
I would, absolutely. I mean, that like we talked about before we came on air, that's the whole reason we do joint replacement surgery is to keep you active. Nobody's going to die from arthritis, but you know, you can be in pain and you can take some pain medication and use a wheelchair, but nobody wants to do that, and we don't want you to have to do that. So that's why we do hip and knee replacement, to keep you active and get you up and moving.
Yeah, it's really painful to go up and down stairs, that sort of thing.
Yeah, just everyday stuff, you know, getting out of bed or getting on off the toilet. Think of that. The terrible hip or knee arthritis that makes it tough.
So the number one thing I can do if I want to avoid having to have a hip knee replacement is to lose weight.
Maybe pick your parents. That might be the first thing. Choose your genes correctly. You know, sometimes arthritis can run in families. You know, if both your parents had horrible arthritis in both their hips and knees, you're likely to get it. But yeah, I mean, and you know, injuries can contribute to arthritis, those kind of things. You know, the whole obesity epidemic is probably in some way contributing. You know, that's a lot of extra force on a joint where the cartilage was not designed to withstand those super physiologic forces. So yeah, I mean, I think weight loss, it's always an important part of the treatment for symptomatic arthritis.
Which doesn't provide any sort of a physical problem, right? It's just the pain.
Well, the physical characteristics of the arthritis are usually, in the knee, oftentimes deformity. It can get more crooked. You see people with a real bow-legged or knock-kneed deformity. Because of the loss of cartilage, there's narrowing of the space between the bones, and stiffness is a common problem with arthritis. But the main reason people come to see us is it's painful.
And aren't they doing some, I don't know if it's in the practice stages, aren't they doing some difference? They want to not do joint replacements. Didn't I read somewhere where they're taking some cartilage from other places, that sort of thing?
Yeah, there are some sort of less invasive treatments for cartilage. Some are in the market right now, some are experimental, and they're for isolated lesions, you know, an isolated area where there's a patch of cartilage gone and the rest of the joint looks fine. It's well aligned and it's stable, the ligaments are normal. Then a cartilage restoration procedure could be indicated for those people. The person that has bone-on-bone arthritis or has significant knock-knee or bow-leg deformity, or are, you know, elderly, more, you know, 80s, those patients aren't candidates for those kind of cartilage restoration procedures.
All right. What's your phone number, by the way, if people wanted to call?
507-334-1601.
Right off the top of his head.
I didn't even have to look it up.
No, you didn't. Could you repeat that, please?
507-334-1601.
1601. So if you think that you need to make an appointment, your arthritic pain is just beyond being able to handle. Again, our text number is 507-838-5233, 507-838-5233. What's the most common question you get?
There's lots of them, obviously. How much pain am I going to be in? How long does it take to recover? How much work am I going to have to take off? Do I have to do therapy? Do I have to stay in the hospital? Those are all real common questions.
You have to do therapy. We all know that.
Yeah.
Seems to be kind
for
of
for shoulder and knee replacement, we feel it's an important part of the recovery. For hip replacement, oftentimes we don't recommend formal therapy. We just have people stand and walk. But for knee replacement, shoulder replacement, those joints require a lot of range of motion to function well, and so usually you have to have somebody in your corner kind of pushing you to get moving.
You talked about the materials when you started versus today. Tell me about the differences.
Probably, I would say the biggest advances I think have been in the plastics that we use. The bearing surface that we use for hip and knee replacement and for shoulder is usually some kind of metal on plastic, and the way they process the plastics and the way they manufacture them has changed a lot, and that's been a huge difference. The wear rates have significantly gone down because of the way they make the plastics.
They're lightweight.
They are, yeah. More importantly, the way they're sterilized makes a big difference, and then they cross-link them so that they're stronger and that they wear better.
I'm glad you brought up the sterilization, because infection is an issue that you need to deal with, right?
Yeah, unfortunately it is. Fortunately, it's uncommon, and but when it does happen, it's a terrible problem to deal with. And that's why the weight loss kind of factors into this. The more unhealthy you are, the sicker you are before the surgery, the higher risk you are for getting a post-operative complication like an infection. So if you're not a smoker, you don't have diabetes, you're in good health, and your weight is reasonable, then your chance of having a good outcome is quite good.
So would you often tell your patient, I mean, do you schedule 6 months in advance, or for a knee replacement, say lose 30 pounds, and then we'll go under the...
I have, yeah. Maybe not that. 30 pounds isn't much, but I've had some people that are 400-pound range, and I told them there's no way I'm going to do your hip or knee replacement until you lose some weight. And I've said that several times or many times, and I've had probably 2 people I can think of off the top of my head that took me serious and lost 100 pounds.
Cool.
Yeah, and then I'm happy to.
Because that's what you're looking for.
Yeah, I mean, you want to minimize your risk. Nobody wants to have a post-operative complication.
Absolutely. And that's true with any joint? The weight issue, shoulders too?
Shoulders, it's more difficult. Oftentimes people carry a lot of that weight in their chest and shoulders, and it just makes the surgery more difficult to do.
So we're talking about every joint, we need to lessen the impact, the pressure on the joint.
Yeah, I think it's a good idea.
Well, Dr. Stromer told me, because I told him I enjoy riding bike, but that's probably the best thing you can do.
Yeah, I agree. I think it's a great exercise, you bet. I think, we want our patients with arthritis to be active. They usually feel better if they're active. They feel worse if they're sitting around. And we usually recommend that you gravitate toward those low impact exercises like biking, elliptical, Nordic track, those kind of things.
Yep, which is what I try to do anyway.
Yeah, it's good.
Well, we're trying. That's all I can say.
It's a work in progress.
We're trying. We don't want to end up, well, my dad didn't ever have to, and he had arthritis, as I told you before he went on the air, head to toe.
Yeah.
Did sit-ups into his early 80s.
Yeah, that's impressive.
Walked all the time.
Yeah, that's key. Stay active. Keep moving.
And that's what he said.
Yeah.
He said, you got to keep
he's a smart
moving.
guy.
Got to keep moving.
Yeah.
So that's what we try to do. But he had a more labor-intensive job than I do, too. So we got to find other ways to stay moving.
Yeah, I think that's true. If you have a sedentary job, you have to carve out some time to be active outside of work.
Dr. Clint Muench is with us. He's from the Orthopedic and Fracture Clinic, based, well, he's actually working in Faribault and Northfield, but it's based in Mankato, right? That's where the headquarters basically is?
Yeah, that's the main part of our group. We have 5 of us, though, on this east side of the practice.
I know you have a clinic up in Lakeville.
Lakeville, Farmington, Northfield, and Faribault.
All over the area. You see a lot of high school athletes, I'm sure.
We do, yeah. Unfortunately, obviously they're getting injured at increased rates as well. And so, yeah, we do work with a lot of the athletes, college and high school athletes.
Any idea why we're seeing an increase in injuries? Because the equipment is much better than when I was a kid.
Yeah, but for the contact sports, the players are all bigger, faster, and stronger. The collisions, the impacts are so much more force than they were when you and I played. And the other issue that we run into is a lot of the overuse stuff, and I think you and I have talked about that before on the air. The single sport athlete that does just one sport year round.
Like volleyball, it's really hard on your shoulders.
It is. Same swimming. That's another sport that's really hard on your shoulders. So those kids have these overuse injuries that we didn't used to see because they used to play multiple sports.
Interesting that you mentioned swimming, because they say that's the best exercise.
Yeah, it's a really good form of exercise. Obviously, it's low impact. Most of us, for whatever reason, don't like to swim.
Do have a texted question here. It says, I have heard there are 2 ways that you can have a hip replaced. What are the 2 ways?
That's a good question. There's kind of 2 main ways to do it. There's more than just 2, but there's kind of the more conventional approach that's been done for many years is called the posterolateral approach. So we put the incision more on your rear end, and that approach has worked well. It's been very durable for many, many years. More recently, probably within the last 10 years, there was a guy in California that kind of popularized a different way to do it, where we put the incision on the front of the thigh and go in from the front, and that's the way that several of us in my practice have transitioned to do recently, within the last several years. And the proponents of that approach from the front, the direct anterior approach, which is what we do, we think that there's less pain afterwards. You tend to move better, meaning you kind of get off your walker, get off your cane sooner, and it's at a year out, there's probably no difference, whether you had it done from the front or the back. A well done posterolateral approach works very well. That's been done in our practice for many, many years and works great. The direct anterior approach is a different way to do it, and I like it a lot. And the patients I've done both approaches on, several years ago, I did their one hip from posterolateral approach, did the other hip from the front. They uniformly prefer the approach from the front. So it's an exciting, newer technique that we're doing out of our clinic, and it works very, very well in our hands.
Well, I know a gentleman who lives in my neighborhood has had 2 knees replaced and his hips.
Mm-hmm. It's common, yeah. Unfortunately,
I call him the bionic man.
Yeah, exactly. Exactly. If you have arthritis in one joint, it doesn't mean you're going to get it in your other joints, but you sure are at increased risk.
And he still is as active as can be. He's in his 80s.
Yeah.
He gets down on the ground, works on small engines and that sort of thing.
Yeah, that's great. Good for him.
I mean, it's a little slower getting up.
Sure, yeah.
But
he can do it.
He can do it pain-free.
Yeah.
That's the main thing, right?
Yeah, exactly.
And the rehab, what's that like for a hip replacement, for example?
Well, it's, like I said, I don't typically send my hip replacement patients for formal therapy. There's really no range of motion exercises that you need to do for hip replacement. We usually have people work on walking and strengthen the muscles of the rear end after hip replacement. After knee replacement or shoulder replacement, that's a far different recovery, and we usually enlist the expertise of our physical therapist to help us regain motion and strength with those joints.
So you don't do squats or anything like that?
We can, yeah. Yeah, I mean, we sure can. I usually just have people, walk.
About knee replacement?
Knee replacement, then we work on range of motion, strengthening, swelling control, those kind of things.
And the rehab?
Yeah, and it's several months of, rehab. Usually seeing the therapist a couple of times a week, usually for several months. A lot of hard work.
And you have to get after it, right? Because if you wait too long, it's not going to work.
Yeah, exactly. Then you get stiff and you're not happy with the way it functions,
So let's say I come in this Friday and I get surgery on my knee. It's replaced?
Yeah.
I'm doing rehab right away, right?
Yeah. Yeah, the day of the surgery we get you moving. Get you up walking and work on the bending right away. You bet.
Little pain medication?
Lots of pain medication. We'll take good care of you.
Okay. Because that's what the number one thing was earlier you said was, back in the day, there was just so much pain. And you've been able to minimize that now.
Yeah, we've made huge progress in that part of the recovery. We use a lot of different medications afterwards that all kind of work differently on pain. We give patients some of those medications before the surgery, and we continue those after the surgery, and we inject medication around the knee to make the pain after the surgery better.
Wow, this listener said they had a cortisone shot and it took 5 days to take effect and wanted to know if that's normal.
Pretty common, yeah. Several days after an injection, the cortisone kind of kicks in and takes effect. Yeah.
Is that something you do before you go surgery route, cortisone?
Oftentimes we do, yeah. Yeah, the thought there is that, cortisone is a powerful anti-inflammatory, and the thought is that it tries to get the joint to calm down. But yeah, that's a good non-operative way to make people better.
How much of that would you do, though, before you say, we really need to go in and replace this?
It depends on the patient. You can do it's safe to do a cortisone injection once every 3 months, and oftentimes it provides several months or many months relief of the symptoms, and then kind of gradually wears off, and the symptoms kind of gradually return. If I usually tell people there's no limit to the number of injections you can have before the surgery. There's a limit to the time between injections. Shouldn't be more frequent than every 3 months. But as long as it's working, as long as they tolerate the injection and it helps, then I'm all for continuing that.
Now you hear about major league pitchers getting cortisone shots more often than every 3 months.
Yeah, and back in the 60s, that was kind of where cortisone got its bad name, as it was overused, and then, there are issues that can go with that.
Such as?
Well, the thought is that if you put it in a joint, that you can make the arthritis worse if you get it more often than you should. Or if you're doing a soft tissue injection around a tendon, potentially the tendon can rupture. Those kind of stories were pretty common when it was overused. We're much more judicious in the way we use it today, and I think it's far safer. And it's a part of the treatment that's real common before joint replacement surgery.
Elbow issues with pitchers, baseball pitchers. You see a lot of that?
Not a ton. I mean, we see, not the kind of end stage ligament tearing that you see in the news that requires the surgery.
Tommy John.
Exactly, Tommy John surgery. Yeah, I mean we definitely do that kind of surgery. It's far less common than joint replacement is, but we do that surgery and we're successful in getting people back to activity. That surgery has evolved a lot over the years as well.
Yeah, the reason I asked that, it seems like more and more younger guys are having to undergo that type of surgery, and Bert Blyleven's theory is because they don't throw enough when they're young. Strengthen their arm.
Yeah, I mean I think, and then that comes back to the single sport athlete, and the playing year round kind of thing. Those ligaments and bones and tendons need rest, in a young arm. And then the other thing is pitch count that we've come a long way with as far as our young pitchers are concerned.
Oh boy, Bert Blyleven doesn't like that.
Doesn't he? Well, Bert and I should talk. When I was a kid, it was innings pitched. You could only pitch so many innings, but if you have a 50 pitch inning, that's different than a 10 pitch inning. So for me, it's pitch count, and I think that's what our kind of governing body, the American Academy of Orthopedic Surgeons, would advocate, would be pitch count.
Well, you'd be happy to know that there was a meeting just last week. I know this because Craig Anderson, the head baseball coach at Pine Island, is involved in this committee. The high school is going to come down with a rule on pitch count. They're just they were trying to, at this meeting, determine what the pitch count should be.
Yeah, I mean, that I think can be argued, but to me, pitch count seems just more intuitive than innings pitched.
Yeah.
So I mean, as long as you're doing something to protect these young kids' arms, that's the key.
So now we need to limit the amount of time the volleyball players, they go year round, those shoulders.
Yeah, exactly.
I'm sure you've seen a lot of young ladies with shoulder issues.
Yeah, for sure. Yeah, that and ACL, volleyball, basketball, soccer, the girls that play those sports are high risk for ACL tears.
So you would recommend multiple sports?
I'm all for that. I mean, I think that's key. I think it makes you a better athlete in the other sports, and gives your, those muscle tendon units time to rest, so that you're not doing the same motor patterns over and over and over again.
Same true with us in our weekend warrior phase. Don't do the same thing all the time, tennis or golf or.
Yeah, I mean, it might be nice to. I'm a huge advocate for getting in the gym and doing some weightlifting and some, some cardio work. I think that's something that, people are kind of surprised when they're 70 and I tell them you should be in the gym lifting weights. They kind of look at me like I'm crazy. Because
they've heard over the years, Dr. Muench, that you can't develop muscle when you get past a certain age.
Yeah, and that's been proven wrong. I mean, it's been shown that no matter your age, no matter how much you're deconditioned, you can build muscle. So get in there, get in the gym and get lifting weights.
And even if you don't build muscle, you can at least maintain what you have as opposed to losing it.
Yeah, absolutely. It's good for your bone mineral content as well. And weight-bearing exercise.
Probably would help, I would think, with as you get older, not having walking issues, teetering issues.
Yeah, exactly. Balance, exactly. It's good. Yeah, exactly. Good for your balance. Prevent a fall and prevent a hip fracture.
Again, what's your phone number, Dr. Muench, if people are interested in coming in and finding out whether or not they are a candidate for a hip, knee, shoulder, whatever joint replacement?
Our phone number is 507-334-1601.
334-1601. And then you'll just ask me a bunch of questions. I would assume virtually anybody's a candidate unless, as you said, you're overly obese or something.
Yeah, or you may have some medical issues that you wouldn't be safe to have an anesthetic for a joint replacement. Sometimes we run into that. But yeah, I mean, typically the way it goes is you come in and we listen to your story. We take a thorough history and then do a thorough physical exam and then likely get some x-rays to check out your joint.
And you guys, I would guess, handle the insurance. I don't have to worry about all that paperwork, right?
Yeah, we have an excellent office staff that takes care of all of that.
Thank you very much.
You bet.
I'm not a big paperwork guy.
No, me neither. That's why we pay good people to do that.
Yeah. Thanks, Doc, for coming in. I appreciate it. Hopefully we can do this again sometime.
That sounds great. Thanks for having me, Gordy. I appreciate it.
Dr. Clinton Muench, he's from the Orthopedic and Fracture Clinic here in Faribault, also out of Northfield and other locations as well. That concludes today's